Thank you so much, all. So it's now time to start the session. A very good evening and a warm welcome to one and all present here. I am Devalina from Indu M Sen. We are proud to be a part of this webinar session as a digital partner. Indu is India's largest live digital CME and doctors-generated medical content platform. You can always find us on Google, www.clearnet.com. So now it's time to start the session. I would like to hand over the session to Dr. Jayashree Shud ma'am for the next proceedings. Over to you, ma'am.
Thank you, Devalina. Good evening, everybody. Welcome to our Wednesday webinars of the Indian College of Anesthesiologists, which we have been showcasing for more than a year. Since COVID started, we've been having them regularly, and we are very pleased to tell you all that the participation of the students and the other audience has increased tremendously, and they are finding it very, very useful. That's because really, if you see the content of the webinars, it's beyond any comparison. And today also we have one very important and such a relevant webinar on perioperative simulation, which I think nobody really covers at all. And we know that perioperative safety is of great concern, and we're all concerned about it. But with simulation coming up in a big way, and that now that it has become mandatory in our educational societies as well, and NABH and as well as DNB and the MCI have made it mandatory, this topic is so essential. And today we are very lucky that we have faculty from different parts of the country who are so eminent and so involved in this subject that I'm sure we are all going to be learning a lot. We have people from right from the north to the south and east all over the country, as you'll see in their introduction. Today, I have great pleasure of introducing our moderator for this webinar, Dr. Indu Sen. She is a very known faculty, not only in India, but also abroad. Indu Sen is a professor in the Department of Anesthesia and Intensive Care in PGI Chandigarh. I know her very well since then, and she is so keen in pediatric anesthesia that she actually got this degree of DM, and she has trained so many people and have in the society of the IAPA, as she has held several important positions. Her area of interest naturally is pediatric airway as well as perioperative simulation training, and she has several presentations, national and international, and she has mentored many students, not only for MD, but also DM pediatric anesthesia. So we are very happy and honored to have Indu to be moderating this session. Indu, could you please start?
Thank you very much, ma'am. Can I share my slide?
Yes, you can share.
A very good evening to all of you. And I'm really grateful to the team of the ICA, especially Dr. Jayashree Shud madam, then Dr. Radhakrishnan sir and Dr. Sanish, for giving me this opportunity to, can I share my slides, please?
Yes, ma'am, you can share your slide.
You have to stop share there.
Ma'am, I have stopped the sharing. Yeah, started.
Thank you. So it's really great to attend these webinars, and I had been attending these ICA webinars every week. They are really informative, and it's good to be at this platform this week. Thank you so much, ma'am. And 3 years ago, I got an opportunity to visit Children's Hospital of Philadelphia as an international observer under that program. And I was really fascinated by the simulation sessions they were having every week. So I wanted to start something similar in the APC or OT complex of my institute, but there was a hesitation about how I will get, there will be the cost involved, then infrastructure, then I need support from my colleagues. I'm really thankful to PediStars. I acknowledge that I attended this conference in Delhi, and especially my mentor, Dr. Dinker sir, then they gave me the concept of shaping the safety culture in the team around you. And it was really like, he made things feasible for me. I'm grateful for that. So today we have three eminent speakers, Dr. Thilaka, Dr. Dinker, and Dr. Vaibhavi. You will be listening to them. Subsequently, I'll just give an overview of simulation just to start the things going on. Well, this is the creation of an experience that is similar to the world around us, but in a controlled environment. It is a methodology and not a technology. Well, the simulation has been used in aviation, in military, in nuclear power, as well as in space lab, so for the quality improvement. And in medical, simulation has also been used, and we will be discussing about that. Adults learn in a different way. So these are the different learning theories which are used for teaching adults. Teach back. So say the retention is maximum when we teach others, and compared to the simple lecture method. Similarly, this is a cycle where we act, then reflect, conceptualize, and apply the principles, and then innovate also. So these are the different theories which can be used for inculcating retention in the adults. So how historically the medical teaching had been. We learned on cadavers, we learned on medical models, animal models as a learning tools. Even we have done dissection on frogs and rabbits also, but now this is not the case. Earlier, this is how a classroom used to look like. There is a teacher on one side and all the learners on the other side. So this is a one-way communication, but the latest way of learning is that these are the round tables where the trainer or the facilitator is also actively participating, and all the participants are also actively involved in the discussion. They are doing things, they are participating. So this is what the medical simulation is. Learning in a risk-free environment, so that this will improve the knowledge, the technical skills, behavior, as well as the systems of care. As Madam Jayashri Sood Madam has already told us that this is the vision of Medical Council of India, that every medical college should have a simulation lab. And many colleges are also having it and running courses successfully. But the problem is the big batches. There will be 100 students per batch, and it is not possible that they will keep rotating in these sim labs. So we need to have something in our work areas, something similar to it, but where the students don't have to pretend, but they actually experience and learn in a safer environment. So this is what the perioperative simulation is. Well, the simulation can be task-driven or event-driven. There can be specific task trainers, and events we can do by role play or by the standardized patients. The role play can be of any role, the patient, the attendant, or the trainer. And we all have been conducting these workshops, like CPR is a common courses which we had been doing, and then chest drain models. So what is fidelity? Fidelity is the degree of realism. This is a term which is used in simulation, and we can have low, medium, and high fidelity models. High fidelity does not always mean that it is high impact. Even a low fidelity model, if properly used, can give high impact to the students. Then this has to be three-dimensional, that is physical, functional, and psychological resemblance has to be there. So it's easy to get the physical, even the functional resemblance, but like the psychological like safety of the participants. This is very important. They have to immerse into the situation, into the scenario to learn maximum. And Dr. Thilaka is the right person to talk about it. She will talk about it in detail in her talk. Then we can have even hybrid simulations where we use the trainers along with the role play. And further, if we these are some simple examples for learning like femoral cannulation. This is a simple doll which has been used in the OT scenario to learn. There are not only the tasks like the skills, we can learn the team dynamics, the shared decision making. All these things can be learned on this low fidelity models. This is a proper like larger model where many modules are there, and it can, but we can simulate something similar to this also. So this was a simple airway trainer. When the COVID started, we got these large intubation boxes. They were as much as the size of the baby, and we were not sure that whether we'll be able to use them or not. So this was done we just see the airway trainer, we use sheets, etc. to make it look like a normal baby. And the advantage of the OT is you have all the real equipment. You have airways, you have the intubation device, the machine is there, and then you can use many free apps are available. Peds Vitals is there, Simple is there, where you can add audio visual impact to your scenario. And if the participant, they attach ECG leads, the ECG will start appearing, but we need a good team coordination for all these scenarios. So this is, there are a few advantages of conducting these sessions in the OT environment. And this is a standard high fidelity sim lab. Here, though they are costly, but it's good to visit at these places once to get the experience how a high fidelity sim lab looks like. And they are really good. You get you get the feedback. Many things can be done on these models. And these are props and moulages which we can use on our low fidelity models. We need to have a certain objective for running a session. They can be remembered by the mnemonic SMART, that is specific, measurable, achievable, result-oriented, and targeted. It's not, don't have too many objectives, have one or two objectives and try to meet them. And then another learning module is the zones, like technology has been used. The example of zone 0 is, say we want, novice learner is there and we want to teach the bag mask ventilation. This skill can be learned by a single person. In the zone 1, the same learner can learn the giving the chest compressions and then giving breaths. So gradually we can improve their skills and then move on to the mock scenarios, and then the behavior of the team can be assessed. We can have system development. So let's listen to Dr. Thilaka. She will be talking about psychological safety, as I said. Dr. Thilaka is clinical lead in simulation, and she's working in the Apollo Simulation Center, Apollo Hospital in Chennai. Previously, she was an assistant professor in AIIMS, New Delhi. Her areas of interest, of course, simulation is there, airway management, obstetric, pediatric anesthesia. She is national editor of a famous journal, and she is involved in the organization of various conferences. She is a member of Indian Society of Anesthesiologists and European Society of Anesthesiology, and she has participated in various conferences and workshops. So Dr. Thilaka, please.
Thank you, Indu ma'am, for the very kind introduction. Good evening, everybody. I'll share my screen now. I would like to thank Team ICA for giving me this wonderful opportunity. It is estimated that over 134 million medical errors occur every single year, majority of which are preventable. The most intriguing question is why these alarming numbers, even when majority of the healthcare providers are reasonably knowledgeable and largely conscientious. Now, the answer is pretty simple. All of us are human beings, and human beings are prone to committing errors. It is really important to identify these human factors like exhaustion, forgetfulness, communication problems, anxiety, and stress. Just identifying these as real issues and addressing them can lead to a significant 50% reduction in medical errors. On top of that, if we could identify system errors or process errors and start addressing those, there will be a huge and significant reduction in the entire realm of medical errors that is happening throughout the world. But the burning question right now is, how often have any of us discussed about these human factors or about system errors when we have ever faced with any kind of event? Now, I don't want any of you to answer this question to me, but I want each of you to answer this to your own selves. Or how often have we seen any of our juniors, seniors, or colleagues discuss about human factors or about system issues? Now, if we look at why we are actually ignoring such an obvious correctable thing, the answer comes out of the fact that the usual organizational culture always emphasizes on avoiding mistakes. So when anybody commits mistake, they are kind of overwhelmed with fear, anxiety, and embarrassment. The sad consequence of this kind of behavior is that no one ever learns from a medical error, and the processes that could prevent further events from happening are not identified and put in place. And the same event sadly could happen again to another patient, and unfortunately, another doctor will suffer its consequences. Simulation-based education is the best way to identify these human factors and the systems and processes that can be put in place. Now, most effective and awesome and amazing outcomes come out of simulation-based education when we are aware of psychological safety and follow psychological safety and make the learners safe while we are conducting the scenarios. So in the next few minutes, we will be discussing a little bit about how to introduce simulation-based education using the existing infrastructure, what actually is psychological safety, the factors that hinder psychological safety, and the ways to ensure a safe space for learning. Like Dr. Indu already mentioned, all of us are actually doing simulation-based education as a part and parcel of our day-to-day practice. And even low technology mannequins can be easily used to create high fidelity scenarios. The most important thing to understand, like Dr. Indu already mentioned, is that simulation-based education is actually a technique and not technology. So we could just start with the existing infrastructure. And if we want to create a realistic scenario, we always try and find out ways to make the situation real. And as and when required, we could add equipment to the existing armamentarium. Now, what is psychological safety? Psychological safety is creating an environment where the learners feel safe enough to embrace being uncomfortable, and they can practice new skills without the worry of being shamed or humiliated. This concept of psychological safety inculcates a sense of confidence in the learners that the team members will not embarrass, reject, or punish them for speaking up. For the purpose of this discussion, we will divide simulation-based education into two broad categories. One will be the skill learning, like in regional anesthesia, ultrasound-guided learning that Dr. Vaibhavi will be speaking. And the second one will be a scenario-based learning for crisis resource management, like the one Dr. Dinker is going to be speaking. What all of us have to first understand and agree is that we are all dealing with adult learners. So adult learners are all self-motivated and goal-oriented people. And they always prefer to learn by doing instead of by listening to lectures or by talking to people. And the most important thing is all adult learners always come with some kind of previous experience, whether it is right or wrong. So when we are dealing with them, we have to ensure that we are treating them with utmost respect and respect to their experience. they might be thinking that it is correct all the time and doing it. So suddenly one fine day, we can't go and tell them that it is wrong. So we need to put it in a way that they will be able to understand through evidence and science to make their practice better. So there is no right or wrong. It is just about improvement. That way we can get across the point to the learners. And when we are going to teach the skills, there are certain ways in which we can create a safe space. Most importantly, if we give them adequate hands-on time and allow them to do deliberate practice multiple times, that itself creates a lot of safe space for learning for them. And we have to keep telling them that it is okay to commit mistakes and to learn from each other's mistakes explicitly so that they don't feel shy when they commit mistakes. Also, we have to keep repeating that the learning curves are different for different people. It's all right if somebody is able to put block with just 2 attempts. It's okay if somebody is going to take 20 attempts, they just have to do it 20 times to reach there. So that is absolutely not a problem to have different learning curves. And the most important thing is that learning is a lifelong process. And 5 years down the line, there might be some technology that none of us are going to be familiar with, but somebody else might be familiar. So this concept of a hierarchical senior and junior, if we can try and remove that from a learning environment, there is only a learner and a trainer. So today I am a learner, tomorrow I will be a trainer. And more importantly, if we have fun when we are teaching people, it kind of automatically translates to the learners and their learning actually becomes fun. And another important thing during skill teaching is to prevent cognitive overload, because there is only so much that a human brain can take in one single day. So instead of giving them the knowledge component and the skill component, everything on the same day, it's a great idea to give them a pre-course study material or reference links that they could go through before itself, so that when they come to practice skills, they can just concentrate on getting the skills right. Moving on to the other bit where we will talk about the scenario-based critical care management and critical event management. Generally, how the scenario is that we will have a pre-brief where we will explain the learners what to expect. And then we will go to a scenario where the scenario runs. Then we take them to a different room to debrief. It's important for us to understand that immersive learning always leads to psychological safety. And when learners feel psychological safe, they kind of can engage better and learn better in those environments. So it's a cycle. The more immersive the learning becomes, the more psychologically safe the learners are going to be. So every attempt has to be made to make the scenario as realistic as possible. And during a pre-brief, it's a great idea to tell the learners what to expect in terms of learning objectives, and as well as the mannequin and the environment. Because if the learners are not familiar with the mannequin and the environment, they don't know what to do when put inside a scenario, and we will not be able to run the scenario. So we'll have to give them some time to get familiarized with the environment, with the mannequin, with the new kind of technique that they are going to do the practice in. And explicitly, we have to make a confidentiality contract by saying that what happens here stays here. So that if somebody is making a mistake, that will not be taken out of that room and they will not be humiliated or will be punished for something similar that happens in a clinical area. This is very, very important. If learners want to discuss something out of this area, we can allow them to discuss ideas and never discuss about people. So this is something we need not take a written contract of it, a verbal contract, but a really serious and a sincere confidentiality contract from all the learners will make everybody at ease and at comfort. Another important thing is to have a fiction contract, which means like we request the learners to consider the environment as real and act as though everything is happening in real life. So once this fiction contract is established, they kind of feel okay when even there are a few problems in our scenarios happen and we have not designed the scenario so well. Even then they behave well, so our scenario runs well. A good pre-brief lays a wonderful foundation for the entire simulation. And at the end of a good pre-brief, we should have learners who are forthcoming and interested and eager, looking forward to what they are going to learn out of the scenario more than how they are going to perform in the scenario. Going on to debriefing. Debriefing is the heart and soul of simulation-based education. It is the essence of simulation-based education because we run the scenario, we give realism, we do all this to create a mindset for the learners where they will be ready to reflect on their actions and will be ready to make changes or to correct whatever can be corrected to make clinical outcomes better. So during a debrief, instead of giving them active feedback, we have to allow them to reflect their own actions and bring about changes that they can do through their own language and their own ideas. So that is when a debrief will be successful. So to make the debrief psychologically safe, there are certain explicit actions and certain implicit actions. If we follow the explicit actions, which are verbal and clear and overt, it's always easy to gain their confidence. So when we ask a question, we have to make sure that we include each and every person in that scenario, because there will be always a mix of population where one will be very talkative and one will not talk at all. So including everybody means everybody feels safe. And when we tend to ask a question, if we genuinely express curiosity instead of passing a judgmental why comment, if we could just ask, like, I'm just curious to find out your idea of what made you do that, that question itself allows them to think and talk. And when something goes wrong in the scenario, or when they are saying something that is not okay, it's important that we normalize and say that, yes, it's all right. It's a difficult scenario. It can happen. It's okay. Now we will look at how this won't happen in the clinical area. So that way we normalize the scenario so they don't feel like they have done something majorly wrong. And it's okay for us to be vulnerable a little. Of course, all of us make mistakes. So it's all right for us to be vulnerable and tell them that, yes, we have also had issues like this in past. Yes, that this kind of problem. So that kind of vulnerability also helps. And we should never forget to appreciate, because when we are doing this debriefing, pre-briefing scenario, there is so much actually happening inside our brain that we are so focused on getting points across the table. In the process, we tend to forget that, yes, we have to say you're doing okay, good. This is something that you've done well. So always remember to appreciate. And there are a few implicit actions which will be non-verbal, subtle, and more attitude-based. So if we just follow the explicit without doing the implicit, like for instance, I'm going to stare at somebody so judgmentally and ask a non-judgmental question, it's not going to help at all. So all these implicit actions will add a lot of value to the explicit actions that we are going to do. Like Dr. Indu had already shown, an arrangement of seats in circular manner kind of breaks hierarchy, because the teacher sits here, the student sits on the opposite side. But when it's a circular arrangement, everybody becomes an equal. So the seating arrangement itself will make them feel, all these, the learners wouldn't know, but these are all things that they will start feeling once they are made to sit in a circular way. And we will have to exhibit behavioral integrity. Like for instance, if I tell them that I'm not going to be judgmental, I have to show that in my behavior also. And when they go through some kind of emotions, which will happen during simulation, they might feel really pathetic for having done something or for not having done something, we have to express some kind of empathy. And the next thing is the most important bit of communication. Actually, I thought, because I am a very avid talkative person, I thought I will be able to debrief well. But then the second I understood debriefing, I realized that I am not supposed to talk at all during debriefing and allow the other people to talk. So we always have to pause to listen and make eye contact with people, not being preoccupied with what question we are going to post next. So when we follow all these implicit actions also, the debriefing room becomes very light and psychologically safe for the learners. And when we ask the question about whether we should pass judgmental comments or not, each debriefer's way of debriefing is very different. We could follow anything, but the whole idea is to make the learners feel like they are not being looked upon as some mistake has been committed. So it is totally okay to be non-judgmental and just ask them to do everything. And it's also a great idea to have good judgment, where we can tell them that, okay, I did notice this. Now my concern is that it might lead to a complication. So I'm just curious to find out why such an action was done. So that is good judgment. Good judgment can be used in debriefing instead of absolutely having no judgment at all. So that can definitely be done. And all of these learnings that we do in a simulation environment have to be used to improve clinical outcomes. So as teachers, as simulation educators now, all of us have this huge responsibility on our shoulders to make hospitals, to make working areas psychologically safe. We have to start from somewhere. So simulation is the best way to start. And when the environment inside the hospital becomes psychologically safe, teams behave very well to each other. They perform very well, and there will be a significant reduction in medical errors that happen. The only thing is it will not happen immediately, but it's going to take a long time to happen, and we just have to wait for that time to come. So thank you very much. I am sure this entire group of audience will have a mix of people who are venturing into simulation recently and simulation enthusiasts who are running simulation scenarios for a long time. So I kept the discussion fairly simple so that everybody will be able to get involved in this. I would love to hear from people who are already doing this. Thank you so much. Over to Indu, ma'am.
Yeah, thank you, Thilaka, for the wonderful talk we had. I'm sure we'll have a lot of questions and we'll get comments from the audience. Next, we have Dr. Dinker, sir. Sir is Professor of Surgery and Director of Simulation Center at Mahatma Gandhi Medical College and Research Institute, Puducherry, India. He's a general surgeon by profession, but active in simulation-based healthcare education for last 10 years. He's a certified healthcare simulation educator from USA in 2016. And he has done team steps, master trainer, agency, then he's into agency for healthcare research and quality. He has done many degrees, taken many degrees from USA, and then has completed the Bristol-Boston Masterclass for simulation. He's NHET Sim certified trainer from Australia, president of Pan Asia Simulation Society in Healthcare. He's a founder, secretary, and life member of Singapore Society for Healthcare Simulation, also a life member of Malaysian Society for Simulation in Healthcare. And he's a board member for Pedestal Simulation Society, India. He's a senior editor for the journal, International Journal of Healthcare Simulation and Advances in Theory and Practice. Sir has got many presentations in his credit, and he has been chairperson of the technical and advisory committees for the simulation of Kerala University of Health Sciences. He's a visiting consultant for simulation at many medical colleges in India and abroad. He's an elected fellow of the prestigious Academy of the Society for Simulation in Healthcare, South Asia. And he has written several chapters and has published more than 50 articles on simulation, education and surgery in journals, as well as in the textbooks. So without wasting any time, let's listen to Sir, and I'm sure you'll enjoy the case vignettes he is going to discuss, and the scenarios. He'll be sharing his own experiences in from the simulation courses he has conducted. Over to you, sir.
Thank you, Dr. Indu. At the outset, I would like to thank the ICA for this opportunity to be part of this webinar. Simulation is something that is very close to my heart. And I must say that ever since I started doing simulation, I consider myself more of an anesthesiologist in my way of thinking rather than a surgeon. So I suppose there's a great big credit to the anesthesiology profession as a whole. What I am planning to do is to discuss team factors or human factors in simulation through the use of some case vignettes. Now, these case vignettes are cases that it was in the simulation environment when we were running simulations in different institutions around the country and in other countries as well. I've just picked up a few of them which I feel have important messages for us in terms of human factors. And this, I hope, by the use of the case vignettes as triggers, it will make it easier to understand how important human factors are in prevention of medical errors, because more than 70% of medical errors have been established in literature to be caused by non-technical skill errors rather than through errors of technical skills. So one thing is, we are all aware that in all professions, not just in anesthesia, we don't have any formal training in non-technical skills, whether at the undergraduate level or postgraduate level. Most of the time, we just pick it up on our own, through experience, practical experience. And that's probably one of the worst ways in which we can learn, because when we are learning through practical experience, it is at the expense of the patients. So simulation is probably the ideal solution to teach these skills to our postgraduates and now even to the undergraduates. So this is the reasons model for causation of error. I'm sure those of you who are in quality assurance who have studied this will understand this model. Essentially what he was talking in terms of industry, but it applies equally to healthcare. So he said that every slice of Swiss cheese has got many holes in it, and every slice of this cheese is acting as a barrier to an error to happen. So there are hazards at every level, and how we prevent those hazards from going into actual errors is what is important. Now, these holes, as long as they're not lined up, we may have occasional latent conditions which may cause error, but because it is blocked further down the line, they don't actually translate into errors. However, sometimes it does happen that all the holes align, in which case you end up with an error at the end of it. So this is, for example, various layers can be labeled like this. It can be that there's no protocol, that may be one Swiss cheese layer. There may be pressures to perform time factor. I know how surgeons keep on pushing anesthetists to give anesthesia quickly. That can be another form of latent errors. And then this, I think, is specifically true in India, a culture of low expectations. For a long time, we've been used to getting away with making errors, which would probably not be tolerated in societies where these errors are critically looked at. And I think all of us have to be honest enough to admit it. So we have been in a culture of low expectations. Now, thankfully, with the various accreditation bodies coming in and with the patients becoming more aware, this is changing. And so ultimately, we also are in what I call a large cultural distance, power distance countries. That means our bosses, we cannot talk back to them. There's a big power distance between the bosses and the subordinates. And while that is something that we are taught right from childhood, that you look up to your parents, don't talk back, etc. While it may be good in the family environment in certain other situations, it definitely is not good in clinical medicine, because sometimes it is necessary for a junior to speak up in favor of the patient. So when all that, when these holes align, you may end up having an error or operating on the wrong patient or whatever it is. So I hope that makes the causation of errors a little more clear. Now, what are these human factors that we talk about? I think Dr. Thilaka had just mentioned it in passing. So essentially, it is talking about people's relationships with everything else. So it could be people's relationship with their working environment. So you may be used to a particular layout in the OT where you have the drug set up in a particular order. And suddenly one day that order is changed without even looking at what drug you're picking up. You pick up the first drug, which you assume to be drug A, but it is actually drug B. You load it and you give it without checking, and that can cause an error. So, or you're working in an unfamiliar environment where you're not familiar with the anesthesia machine that is there, and that can lead you to make some errors. It could be people's relationship with, working environment is more like unfamiliar environment, finding out where things are. And I was talking about the equipment just now, relationship with equipment, where you may not be familiar with a new piece of equipment like a defibrillator, very classical example. You need it in an emergency. You don't have time to learn about it, but the knobs and dials may be different from what you're used to. So you may be fumbling at the time when a patient needs defibrillation. So, and people's relationship with other people, when they're working together as teams, it is imperative that people work as a cohesive unit. The weakest link in the team is is the one that makes the team performance falter. So it's this people's relationship with other people is the other important human factor. If you look at the key concepts, I'm sure a lot of you will be familiar with this. So when we are talking about human factors, it can fall into the following categories: the role allocation, where you make sure that every person is allocated a role appropriate to his or her level of expertise. Communication skills, a lot of miscommunication causes errors in the medical environment, especially in critical situations which anesthesiologists are quite familiar with. Global assessment also, which I would like to call a situational awareness, where you have to be aware of everything that is going on around you, not just with the patient, but also in the environment, also with the other members of the team, whether they are performing, not performing, etc. Mutual support to help each other and also to call for help as required. We sometimes have an ego fixation that calling for help means I will be seen as not efficient enough or not qualified enough. That feeling has to go. So we should always be ready to call for help whenever required and making optimal use of all the resources that are available. So in a nutshell, these are the key points that we think about when we are talking about human factors. Now, the anesthesiologists are the ones who took a lead in team training simulation for human factors, and this has been going on from the late 1960s onwards, in fact. And this is now a Bible as far as anesthesia is concerned for non-technical skills. It's called Anesthetist Non-Technical Skills, which you can see has been produced by the University of Aberdeen and is universally used not only in the UK, but all around the world. And they divide the non-technical skills into these four major categories of task management, teamwork, situational awareness, and decision making. So this is something I feel that all anesthesiologists have to be familiar with. And in fact, in the UK and all, it's compulsory for anesthesia residents to go through training in all these areas through simulation. Now, so we are going to be looking at 5 case figures. I'm sorry, I think I mentioned that wrongly there, and what lessons we have learned from them. So first of all, I'd like to play a small video. I apologize that the sound quality in the video is not very clear, but I'll try to correct that by giving a voiceover in the video. So essentially this video is, you can see it's a simulation environment. The video has been deliberately exaggerated by the players in order to bring home the messages. So it is not what you would see in real life, but they have deliberately exaggerated it so that the lessons become more clear. But you can see the anesthesiologist, he is a theater assistant, and we have a nurse who's basically not very experienced. So that is a team, and he is required to do a rapid sequence intubation for a patient he's not familiar with. He's been called in from another OT to do that. So I'll just play the video and you can have a look at it. And we can look at it with the idea of how the teamwork is going on, what are all the various issues in teamwork, and especially this fellow's leadership. So he's just introducing himself to everybody. So she's been asked whether she can do cricot. She says no. So he just says you press over here. So She says SATs are 89, 90. He is offering help, but the anesthetist is saying, no, no, I'll manage. You can see that he's had nothing ready from beforehand. The bougie is being opened only now. Patient is going into bradycardia. Okay, so we saw that everything that could go wrong in this particular scenario went wrong. And if I were to just summarize in a nutshell, we saw that he was not familiar with the capability of the team members. When a number of times the experienced anesthesia assistant offered to help, he turned him down. You saw that he called for help very late. He was very rude and short with his assistants, which because of his tension, of course, but that means that the assistants are also nervous and they will not be performing to their optimum level. You saw that he was not properly prepared. So essentially, this highlights, all the errors that we can make while performing a critical action. So from here, I will go on to the various cases. As I said, these are real cases. When I say real, I mean in the simulated environment, but cases that can very well occur even in real life. So the first one was, it was a scenario that was planned as anaphylaxis under general anesthesia. And what happened was, after the general anesthesia, I think antibiotic was given as a on induction, and then the patient became hypotensive, developed bronchospasm. And essentially for the participants, the end point of the scenario was epinephrine administration as per the local protocol in that institution, among the other measures that they have supposed to take. And what we found was that because this mannequin recognizes the drug that is given, and we can see on the computer screen what drug has actually been given. So participants gave a very large dose of epinephrine. That was the end point, but the dose they gave was very large, and the patient went into ventricular fibrillation and the patient arrested. So we were not very clear as to why they gave such a large dose of epinephrine. But when we did the debriefing, we found that at that time only the participants realized that they had given epinephrine when they thought that they were giving ephedrine. Because of the hypotension, they had a knee-jerk reaction. They wanted to give ephedrine, but they gave epinephrine instead. And I think all of you will agree that these things can happen in real life. So this was not something that we planned for during the simulation, but we just, this happened by accident. So you can see that simulation can have very valuable spin-offs which may not necessarily be planned for beforehand itself. So now, for every case, I'm going to decide the lessons learned. I'm going to look at it from the point of view of the participants, as well as from the point of view of the facilitators who are running the scenario. So if you really think about the human factors that contributed for this case, which was a wrong drug administration, the participants were under stress because they needed to do something urgently for a patient who was crashing under anesthesia. And you know that ephedrine and epinephrine sound similar. Maybe they just read the EP and went for the drug. And the vials, were not very well clearly distinguished. They were loaded in labeled syringes, so they couldn't distinguish very clearly. And they just had a need. So this is another common thing that we find, which is not a bad thing necessarily. When the patient is is crashing, the first step is, of course, to treat the condition. So if the patient is having hypotension, try to bring up the blood pressure. So that's not necessarily a bad thing. But at some level, you have to step back and think, why is the patient crashing, and treat the underlying condition so that the patient gets better. So here it was the ephedrine given was just a knee-jerk reaction to the hypotension, and unfortunately they gave epinephrine instead, which was not planned for by the facilitators for the simulation, but which happened in the scenario. So what are the lessons that we learn? Drug errors are easy to make. In fact, this opened the eyes of the faculty in that institution, and they said that we must make sure that in the real OT, we label the epinephrine ampoules very clearly so that this error does not happen over there. So we can get unintended learning issues during simulation, which we did not foresee. And simulation can improve hospital process workflows, which Dr. Thilaka had also just touched upon. Here they decided to make a change in the way they work in the OT so that this error does not happen over there. And if you look at it in terms of the ANTS framework that we had discussed, so you can see that there was an issue in task management where, they did not plan and prepare properly. They did not know where the drugs were possibly, and that's where the confusion came. There was definitely an issue with teamwork. And there was a situational awareness was a problem because they picked up the wrong drug and gave the wrong drug. Until the very end, they were not aware that they were giving the wrong drug. So that was case number 1. Case number 2 was an undetected heart murmur. So this was a patient who was undergoing an elective surgery, but they had a mitral stenosis murmur, which was missed during the pre-anesthetic checkup. And this, though it was a simulated case, it was modeled on a real case. I think Dr. Thilaka was mentioning about the fact that we need to make the cases as realistic, the experience as immersive as possible. And one of the ways you can do that is to model your scenarios on real problems that happened in the OT and bringing it into the simulation room. So this was actually a real case which had happened in the institution, and they reprogrammed it for the simulation. So this was not recognized preoperatively, and patient had hemodynamic issues intraoperatively. The junior team member detected the murmur, but they did not escalate to the senior because they thought that the senior must already know about it. They're so senior, they're experienced. So I'm sure if I tell him something, he will yell at me saying, why are you telling me something that I already know? So the junior team member did not escalate this to the senior. So as a result, the patient suffered hypotension, and eventually I think the patient went into arrest, simulated patient, of course. So what are the lessons that we learned from this particular case? So basically, we know that pre-anesthetic checkup is not infallible. Sometimes it is worthwhile whenever you are taking over a case in theater to check the case for yourself once again to see that everything is okay. I know this happens as a routine practice in most anesthesia practice. But having said that, there are some times when this may be, this may slip because of the pressure of time or whatever it may, the reason may be, or the surgeon is hurrying you, or you feel that you have to intubate the patient quickly. This may be missed out. So it's important that we follow a specific protocol. Unanticipated events can always occur under general anesthesia. Again, there was a knee-jerk response to the low blood pressure over here. They did not try to analyze why the BP was low. When the expected response of BP did not come up when they did all the treatment that they thought was appropriate for the patient. And of course, you must listen to your juniors because everybody may have something to contribute. And sometimes a junior may be in a better position to contribute because they are not having the same level of stress that the senior who's directly caring for the patient is having. They are stepping aside in a way, and they're looking at it from a distance. So they may be able to tell it without, they may be able to mention it to the senior because they are more aware of things that are going on. Lessons for the facilitators. develop a psychologically safe working environment. Now, Dr. Thilaka was talking about a psychologically safe simulation environment. I think through simulation, we must learn to also make our work environment psychologically safe, where it is safe for a junior to speak up and not get punished for it. Everything cannot be anticipated and planned for. So this is where experience counts. And the more number of simulations you do with these sort of unexpected scenarios, the more experience you will become at it without necessarily harming real patients. Develop some algorithms for troubleshooting. So hypotension under anesthesia, hypoxia under anesthesia. I know most of the seniors amongst the audience have it in their mind that if such an event occurs, these are the steps I will take. But for many juniors, it is not so easy for them to know these steps. So if you prepare this particular, as a protocol and have it available in the OT, it may be easy. Like pilots have checklists of what to do when one engine fails, when two engines fail, etc. And when I was working in Singapore, the anesthetists had what they called the red book, where all these possibilities were mentioned, and you had to open to the right page and go through the troubleshooting checklist if anything like that they faced. And emphasizing collective decision making is very, very important. So if you look at it again in terms of ants, so here I think all four aspects were involved. From the task management, where obviously the planning and preparing was not adequate. They missed a mitral stenosis. The teamwork, situational awareness, because they didn't know what was going on with the patient. And in teamwork, communication between junior and senior, and decision making also was faulty over here. So the third case is that of a soda lime disconnect. This was, again, this was done deliberately. The soda lime canister was disconnected for the participants just to see how they would respond to an equipment failure. And in this situation, this machine was a very, very advanced machine, where the moment the soda lime disconnect happened, the monitor is flashing alarms to say that there's a soda lime disconnect, and the patient's CO2 is keeping on rising. And the participants, in spite of this alarm on the monitor and the monitor flashing, they missed it. Sometimes you may think, how can somebody miss such an obvious thing? But I can say from experience, and I'm sure all of you will agree, that it's quite easy to miss very, very obvious things, the elephant in the room, as it were, because you're preoccupied with other things. So they ignored the machine alarms, and there was inadequate troubleshooting of the rising CO2 levels. So what were the contributors in this particular case? So something that I would like to call the cry wolf syndrome. What happened was that we are so used to getting alarms for small inconsequential things that the first reaction when we get an alarm from a monitor or a machine is to silence the alarm, rather than looking to see whether there's any genuine cause for that alarm. Especially when that alarm comes up very, very frequently, the first thing our finger goes to the alarm silence button. So this is probably one of the things that contributed. Poor situational awareness. They were not aware that the soda lime canister was disconnected. They were not aware of the flashing alarm or the flashing sign on the screen also. They were not familiar enough probably with the equipment, and the decision-making process was poor. So what is the lesson for us as facilitators from this? We need to train our residents not to ignore alarms. Always treat every alarm with seriousness, and only when you see that it is inconsequential after doing your troubleshooting, you can then silence it. Equipment orientation is a must for junior anesthesiologists, because in every institution the equipment differs, and one of the first things you do is to bring them and familiarize them with the equipment rather than throwing them in at the deep end to anesthetize a patient. And give some troubleshooting scenarios so that they become more familiar with the equipment, like this one. Give them a soda lime disconnect, give them a circuit disconnect or a block, something give them so that they know how to tackle that. And you must train them for equipment failures. And again, you must have troubleshooting algorithm for equipment failure as well. So if you look over here, again, task management was lacking. Situational awareness was definitely lacking. They didn't make out the fact that the alarms were flashing, and decision making was very poor over here. So the case 4 was an esophageal intubation. This was again deliberately planned. So what happened in the case was, this is a patient who comes into the emergency department because of head injury with a low GCS, which requires intubation in the emergency department. But the patient is breathing spontaneously. So the ED physician deliberately puts the tube in the esophagus because for the sake of the simulation, patient is breathing spontaneously. He's bagging the patient with the ambu bag, and he's bringing the patient to the OT, where he hands over the patient to the anesthesiologist. He's a very senior ED physician. He hands over the patient to the anesthesiologist and says that I've intubated this patient and I'm bagging. First thing anesthetist does, he or she checks the air entry and sees that the air entry is equal on both the sides, and they believe it is because of the bagging. The moment they give the non-depolarizing agent, the patient stops breathing, and obviously because the tube is in the esophagus, the bagging has no effect and the patient crashes. You would think that they would immediately realize that the tube is in the wrong place because you're not getting any CO2 readout. You're getting every evidence to say that the tube is in the wrong place. But you'll be surprised, we ran these scenarios after the initial success several times in many institutions, and everywhere they did not pick up that the tube was in the wrong place for a long time. And the reason for this is something that is called as fixation error. They seen for themselves the chest rise and fall with bagging when the patient was breathing spontaneously, and they believed that the bagging was responsible for the chest rise. So they've already made up their mind that the tube is in the right place. And that led to this error over here. So the contributors were fixation error. So it can be anything but the tube in the wrong place. Poor situational awareness, and again, poor decision-making processes. And the lessons for the facilitators: train residents to step back and reassess. So you have something going wrong and your actions are not improving the patient. Always think, am I missing something here? Is there something else that is going on? All possibilities need to be considered. And this is where a team huddle, where you discuss with each other in the team, can help, because many minds make work light, right? So somebody may come up with the idea that maybe the tube is in the wrong place. Challenge, if you think that something is wrong, challenge the senior as required. And again, the algorithms, troubleshooting algorithms we talked about earlier. So here, if you see again, all four aspects of ANTS were compromised. Task management, the teamwork was lacking, situational awareness was very poor, decision making was very poor. The final scenario that I'm going to talk about is a scenario on COVID preparedness, which we ran in our institution. And here I'm not going to blame the anesthesia. This scenario is not, the fault was not in the anesthesia section, but with the surgeons. So this was an interdisciplinary team training where we had anesthesiologists and surgeons. Case is a patient of trauma needing to undergo surgery for hemodynamic instability. And this was in the height of the COVID that we ran this scenario. And we said that the patient has come in with breathlessness. Now, we had planned it that this breathlessness is actually because of COVID and not because of anything related to the trauma. The anesthesiologists, prepared themselves very well. They donned full PPEs before intubating the patient. But the surgeons, to our surprise, though the PPEs were available, they didn't use them. They just came in without the PPEs and examined the patient, because somehow in their mind, they thought this is a case of trauma and not a case of COVID, because it's come after a road traffic accident. And these things can happen. We think, just because the patient is that patient of trauma does not mean he cannot have COVID. But our mind is made up that this is a patient of trauma. Again, an example of a fixation error. So, COVID is not possible in this patient. So they did not really wear any PPEs. And that became a major issue that we had to address during the debrief. So the contributors in this case: fixation error, that this cannot be COVID, and poor situational awareness. Firstly, again, all possibilities to be considered. Some of these things we need to conduct regular drills. We picked this up only because we ran this COVID drill. And after this, I'm sure the surgeons who participated in this scenario never forgot to wear PPEs when they saw a patient in the real life, regardless of what they thought the patient was having. And we should have management mandatory requirements that you must wear these things when you are faced with a COVID situation. I know COVID is on the wane today, but tomorrow it may come back, or some other infectious disease may come. So we must always be ready for these eventualities. So if you look at the problems, there was a problem in the task management, teamwork, because they saw the anesthetists donning, but they did not don the PPEs, and situational awareness was poor. So these 5 cases, I hope, illustrate the fact that most of the errors that happen in any discipline, and particularly in anesthesia, are related to human factors, related to non-technical skills. Patients do not necessarily die because an anesthetist does not know how to intubate. If it's a difficult intubation, even a senior may fail. Such patients may die, but that may be an unavoidable death. But a lot of deaths occur because of human factors, which are all avoidable deaths. And because we don't look at the root cause analysis of many of these events, we fail to identify the underlying human factors which are causing these deaths. So in summary, we know that anesthesia practice is a high stakes practice. Critical events occur from time to time. and they are due to non-technical deficiencies, and we need formal training to improve these non-technical skills, and simulation is the key to imparting these skills. So I hope that I have emphasized the importance of non-technical skills, and I hope I have opened the eyes of the participants in this webinar to be aware of these when you are training your juniors, and if you are juniors, being aware of the need to imbibe these skills so that we don't make errors in this area. Thank you very much.
Thank you so much, sir. All 5 scenarios which we have discussed, they were quite relevant, and I'm sure the participants have learned a lot from these scenarios, and they will have some questions also. We will have questions at the end of this webinar. After we can complete the next talk. Next talk is by Dr. Vaibhavi. And as we all know that regional anesthesia is an important tool in the armamentarium of the anesthesiologist, either alone or as in combination to the general anesthesia. So Dr. Vaibhavi will be talking about the simulation-based like regional anesthesia, and she is like clinical lead in simulation. She's an anesthesiologist by profession and is a member of CPR committee, patient safety committee, education committee, and the COVID task force. Presently, she is affiliated to Dinanath Mangeshkar Hospital and Research Center Pune, and also the Bakul Tambut Nursing College Pune. She's a simulator instructor in the D.Y. Patil University Simulation Lab, Navi Mumbai. And coming to her major achievements, there are so many. Regional anesthesiologists with proficiency in ultrasound, WFSA certified BAST simulator facilitator, certified from the Mayo Clinic for comprehensive as a comprehensive simulation facilitator. She is Livebox certified safe operation room simulator instructor, PDSTARS member, as well as the faculty, executive member of the Society for Healthcare Simulation, and instructor in the University of Hong Kong. She had been there, and executive member of Academy of Regional Anesthesia, associated with Hong Kong University and Axon Anesthesia Associates. She had been an invited speaker to various courses, and she is conducting workshops related to simulation for anesthesia, focus, clinical skills, and human factors, and research in simulation. Dr. Vaibhavi is going to use an app, www.menti.com. So all of you are requested to use Google for downloading that, and then answer to the questions put in the during her talk, and keep it on throughout the talk till the end of it. Over to you, Dr. Vaibhavi.
Thank you, Dr. Indu, for such a kind introduction, and a good evening to all participants. It's a pleasure to be here amongst ICA and ClearNet for a wonderful conference through webinars. Today's topic is simulation in regional anesthesia. Since regional anesthesia is close to my heart and been practicing regional anesthesia for the last almost 15 years, there's a lot to share how simulation can be applied in regional anesthesia. So a disclosure, there's no conflict of interest. So here, before the participants have already deciding what is on menu for dinner, I would invite all participants to come and interact with me in this session. How can they interact with me? There are 2 ways. One, you can toggle with www.menti.com, or you can use this QR code and enter this numeric code that you can see. Once you do that on this platform, you can actually talk to me, and whatever you type comes on the screen. So it's like a live chat that we are doing. This is one way. Second way is through the ClearNet web page. Whatever inputs, questions you have to put, you can do that. It will automatically come on the Zoom chat, and our moderators will bring it to us. So let's begin. Okay, so let's begin with a poll. Okay, so there's a question to all of you. Would you please let me know in which category do you all fall into? So are there students here who are present who are undergoing training for anesthesia? Are there anesthesiologists who are practicing in medical colleges? Are there anesthesiologists practicing in private hospital? And many of them might be in administrative role as well. To do this, I kindly request all of you to use this QR code or go to www.menti.com. You can toggle your window through Google, you can minimize Zoom, or you could also use another phone for that. Okay, so I'm going to give you 1 minute for this. There's a countdown that I will be putting. Okay, so we have 1 minute here. Fantastic. So we have participants who are equal at present, who are undergoing training, who are either in medical colleges. So let's keep the numbers coming in. Please remember, this is a multiple choice question. You can choose more than one option as well. Okay, excellent. So here, as we look at, we have a wonderful mix of people where we have students in a good number. We do have anesthesiologists in administrative role. We also have anesthesiologists in a medical college. And now that you can see, suddenly the numbers change, and we do have privately practicing anesthesiologists as well. I guess the numbers are pretty much very clear to all of us. I'm going to close the voting for now and take you to the next slide. Okay, so here comes another question for all of you. Okay, so just go to the next slide on the app that you're using. You can see a small thing. Go to the next slide, click on that. Yes, we would like you to answer these 4 questions. Who are currently practicing regional anesthesia? Okay, who are keen to learn about regional anesthesia? Who are keen to teach regional anesthesia? And the 4th category is we are not interested. Okay, I mean, those people are welcome as well to listen my talk and maybe decide if they are interested in future. So let's look at who is keen to teach RA. Yes, they are keen to learn and currently practicing as well. So let the numbers keep flowing. Here I'll give you a countdown of 30 seconds. Okay, so I'm inviting all to use menti.com and use the code that's mentioned on top of the slide. Okay, so currently practicing regional anesthesia, anesthesiologists are majority, and I'm glad to see this because this session will be relevant to all, even to the students actually. All right, so let's close the voting for now and let's take you to the next slide. Now, there is a question to all of you, all the participants, be it students, be it practicing anesthesiologists, be it administrative doctors who are into administrating management. What are the challenges for all of you to learn or to teach or to practice regional anesthesia? Could you please type in your word, actually, a word or 2 words. You can actually type the words on menti.com using this code above, and this word will flash on the screen. Yes, to teach ultrasound guided learning regional anesthesia. Okay, that's a challenge. Okay. Any more challenges that you're facing, so that during this session, how can simulation help you overcome that? We're going to look at that. Okay, so I'm going to give you a time for 1 minute. Yes, to learn ultrasound guided blocks. Okay, learning blind blocks. Okay, fear of block failure, right? Availability of ultrasound. Yes, in the field in India currently, because of the PCPNDT Act, there is a limitation on usage and availability of ultrasound. We are going to look at another options, how we can learn about it. Equipments that's available. Cooperation of surgeons. I think Dr. Pai is here, and I'm really glad that we have surgeons on board as well, who can look into this, that this is a real challenge that we may face when we are going to learn regional anesthesia, teach it. An equipment lag, the number, teaching methods. Here is something that I would like to address, how simulation as a methodology is going to revamp the whole learning and teaching techniques in regional anesthesia. Okay, we do need mentors. A fantastic word has come up, which is a mentor, and we need people who are aware in simulation techniques so that these mentors can actually give simulation-based training to our students. Fantastic. I think, thank you so much. I think I'm going to close the voting. Is closed already. And let's go to the next slide, where what is actually simulation in healthcare? Dr. Pai and Dr. Thilaka has brilliantly put in the entire fundamental blocks, the building blocks in the initial 2 sessions. And I'm really glad that they spoke first, because they have really laid out what are the components of simulation that will help us in healthcare. So here I'm generally talking about healthcare, be it medical or be it nursing education, just a brief categories of: 1, how do we educate our students? 2nd, when we work in our clinical practice, what do we do? And lastly, as a system in the hospital, where simulation could be a part of it. So as we see here, education, yes, largely spoken about how do we teach, how do we learn, clinical healthcare, multidisciplinary teams, how do we make teams stronger, which Dr. Pai spoke really well, and Dr. Thilaka did mention about the psychological safety so wonderfully to really bond the teams together. Systems is where we're going to look at how interdepartmental teams like anesthesia, surgery, ER, ICU, how are they going to come together using simulation to form interdepartmental teams as well. Actually, achieving organization goals through this. Okay, so what is the evidence? Simulation in medical education has a critical review done by William McCarthy, and this article beautifully actually shows, evaluates the historical and contemporary research on simulation-based medical education. It does show 12 best practices. These are the 12 best practices that would be used when we use simulation-based medical education. 1 is, how do we give feedback? Do we do deliberate practice, and finally we reach a stage where we are competent and maybe even a master? The curriculum integration, the outcome, the learning outcome measurement. How do we assess our students? The simulation fidelity. Fidelity is the realism that we bring into for them to even experience what happens in the real world, and they are prepared to not get overwhelmed because of this. How do we become masters? So we want competent people, but we also need masters as they grow in their field. Then team training. Team training, Dr. Pai has so integrally spoken about how teams can make a difference, especially due to the human factors that come along. Then the transfer to practice. How is it that these trainings actually are benefiting the flow, the clinical flow, where the clinical teams are working around real patients? Then comes high stakes testing. That means research involved in whether this education methodology and at the same time the outcome of the clinical outcome, the patient safety outcome, how is it tested? We largely look into the training potential of the trainers as well. How do we make good trainers? So simulation is going to actually benefit these 12 best practices in medical education. Now let's look into regional anesthesia, this topic which we have today. What does this topic tell us? A scoping review was done and there was evidence. How is this taught in our Indian setup? Okay, so we're going to look at using this study, and it's a wonderful study which actually makes us realize that these best practices actually help us become better in a specified field like regional anesthesia. There are many more. There's obstetrics anesthesia, there's pediatric anesthesia, but today let's look into details of regional anesthesia. So the feedback, what kind of model are we using to give feedback to our students? Can debriefing also improve the model of feedback that we are giving with a lot of psychological safety? Deliberate practice, the dose response relationship that we have to be verified with repetitions. to know about the learning curve. And yes, every learner is different. Like Dr. Thilaka mentioned, every learning curve could be different for different students. But how do we know that the dose response is either it is less or it is more, so that we can help and give remedial trainings to the students? The curriculum integration, the educational objectives, more smart they are, more clear they are. With the apt learning modalities that we are going to show now, actually can help simulation to be integrated with the curriculum. The outcome measurements should have statistical data as well. The fidelity, the skill acquisition and maintenance. Many people think, oh, once we acquire it, and the students feel is we acquire it and it's done. But no, to maintain it is also what is mandatory. And hence, a simulation control lab provides them opportunities to practice their skill, even if a patient is not available for the same skill that may required for training. Lastly, we'll also see team training. The ones in red are especially the ones that need to be strengthened, and simulation can help here. The team principles and the training education, the training of trainers, which also need to be strengthened. Okay. So simulation in regional anesthesia again has three components like we saw. One is education, second is clinical healthcare practice, and the third is system thinking. That is the systems that we work into. So the regional anesthesia education has three components: KSA, knowledge, skills, and attitude, which is a mandate as an undergrad or a post-graduation student or a fellowship program for that matter. The clinical healthcare work that we do actually requires multidisciplinary teams to come together. And lastly, the system thinking, where we require the organization or patient-centric goals to be achieved, the safety goals. So we're going to take one at a time. So regional education, regional anesthesia education. Here, the knowledge content delivery is done by didactic presentations, videos, online case-based problems, e-learning modules. And Dr. Indu very rightly mentioned the retention capacity, the retention pyramid did show that these actually can have quite a less percentage of retention, and the highest when the students actually teach or probably they actually do the procedure. So apart from this, how can simulation help? So here, to strengthen regional anesthesia knowledge, we require a robust understanding of anatomy. If anatomy is made 3D, virtual, actually, it could really benefit for us to understand which nerves are there currently in this area through surface anatomy, which nerve is there passing through the muscles, which layers of muscle, which fascias engulf them. So actually having a virtual and augmented reality, which can also incorporate ultrasound images, which is the current trend in regional anesthesia to have ultrasound guided regional anesthesia. These simulators, such as the anatomy table on the left here, the AR and the VR, virtual reality, augmented reality, as well as certain apps on the phone that can give a 3D appearance to the nerves that are going through the muscle planes, through the facial planes. This understanding makes us robustly understand and teach our students. Also, the students can learn on their own through these. So this is where simulation can help, and most of our medical colleges are moving towards this, as in the NMC is mandating. So now let's look at the skill development. Regional anesthesia is a skill-based profession. It's hardcore skills, and we need them. That's the most important crux. And hence, skill demonstration and skill practice is paramount through rapid cycle deliberate practice. So let's look at the needling practice. How can simulation help us achieve the hand-eye coordination, the visuospatial coordination that is required for us to actually improve our needling techniques? So as we can see here, there are certain gel blocks which are commercially available and that could be used for ultrasound guided nerve block teaching as well as learning. We can also have low-cost cornstarch cake modules, which can be made. Of course, their shelf life is less, but it could be still one of the low-cost modules that we could make in our own kitchens or the pantries in the sim labs and use it for needling. The other options for learning regional anesthesia skills are also cadaveric needling. That's very popular because it's almost near realistic. The real fascias, the real nerves, the real muscles could be visualized. Unfortunately, last 2 years, due to COVID, cadaveric dissections were limited due to fear of infection. And hence, the other options which were explored were simulators or task trainers, which provide us ultrasound-guided regional anesthesia practice. And these are available in different simulation centers, which could be accessed to actually practice the ultrasound-guided spinal or epidurals, as you can see here. We can also practice ultrasound-guided needling practices. We can see a tab block being performed here. Apart from this, we could have simple suturing pads for suturing the catheters that we are going to introduce in the patients. So absolutely all skills that are required for the skill of regional anesthesia, we can perform on the simulators and the task trainers. And of course, one of the challenge that was mentioned during the initial slide by many participants is non-availability of ultrasound machine and also the learning curve to know the ultrasound machine. So in those patients, I think many in those setups, many anesthesiologists use a peripheral nerve stimulator. This peripheral nerve stimulator is connected to the needle, and we do search the nerve by stimulating it with the current. Now, we do have transcutaneous nerve stimulators, which could be used in simulation to actually elicit the desired muscle contraction response and to find the nerve. And this is a practice that you can do it on your own body as well. So this is one way in which simulation can actually show you that the nerve is found in this way, and this is what the contraction that can look like. So of course, this can be used only for superficial nerves, not for deeper nerves. Now, as we all know, regional anesthesia practice involves handling of or dealing with a lot of critically ill patients. Predominantly, the reason being they cannot tolerate general anesthesia. Probably the lung cardiorespiratory conditions are quite bad, low EFs, and that's where regional anesthesia skills come into play. So most of the patients can be critically ill, could be very sick, and they could decompensate. And hence, there are a lot of added modalities that we may need to learn, such as having a central line in place. We might want to look at the preoperative echo of the patient, maybe intra-op as well, and post-op. So having the knowledge of these additional skills as a perioperative physician can also be practiced in simulators. We can see one here on the left, which is central line simulator, ultrasound guided, needling could be practiced. On the right, we can see the transthoracic echo, which could be practiced through a simulator as well. Finally, we come to the professional attitude that requires to actually be a regional anesthesiologist, such as talking to the patients, having a professional communication, take an informed consent, explain complications, breaking bad news. Okay, so these require simulated patient. That means you require a role play. Most of the times we do have co-facilitators who are more than happy to follow a script and be a patient to actually be examined and spoken to by our learners. And that really actually makes a difference because the simulated patients have a clear script that these are the things that they are going to perform and speak when they're asked about. So for example, how do we take an informed consent? Okay, how do we break bad news, such as an epidural catheter has broken and half of the piece is inside your body, okay, inside the patient's body. Post-dural puncture headaches, how do we speak to the patient, we explain, and how do we treat? Neuropraxia, local anesthetic systemic toxicity, if it happens, how do we explain to the patient post-operatively? So there are a lot of aspects that we need to talk and explain and role play, which is an integral part of simulation, and it helps develop the human factors as well. Then we come to, as we kind of go into the details of education, we can use standardized checklist to reduce learner, educator, and assessor bias. Okay, so even if the educators vary, the checklist actually makes sure the objectivity remains in the teaching. Even if a learner who has a different learning curve, with the checklist would also make sure that certain critical aspects need to be honed on based on the checklist. And the assessor bias during the assessments, such as the formative as well as the summative assessments, could be also looked into. Okay. Then what we do next is, okay, sorry, I think, yeah. So we had done a small study here where we looked at a TAP block blue phantom was used in assessment and quality improvement of the anesthesia department, a prospective comparative study done by a team of us. We used a procedural checklist, and we also checked whether cognitive load assessment is done during this time. So a procedure was learned newly in a group of anesthesiologists in the department, and we also looked at whether they learned the procedure as per the checklist. At the same time, we also learned the cognitive load that happened on these when they learned it in simulation. And we actually have quite a beneficial report. This is accepted in the IGRA, and it will be published in the coming issue. So I would request all of you to go through this and see how the results have been beneficial. Next, we come to our working teams, our interprofessional, multidisciplinary working teams on the floor. So of course, here, Dr. Pai has brilliantly put in all the concepts of CRM, task management, situational awareness, decision-making, and leadership skills with communication has been in-depth spoken about, and I will probably not go into details for the same. But related to regional anesthesia, what are the cases that we can actually practice through simulation? One, pneumothorax, local anesthetic systemic toxicity, high spinals, post-dural puncture headaches, and many more. Here, we look into not only the clinical case management, but we also look into the human factors, the CRM principles, and we make sure that the simulators are appropriate for this. We do not need a high technology simulator, but yes, we require high fidelity. So even if in a low resource setup, we still can develop high fidelity using the methodology of simulation. But most importantly, the soul of simulation. Simulation is like, it's like a role play, it's like a methodology, but the soul of it is debriefing. So debriefing largely is the experiential learning cycle with a close, small team who sits together, one-on-one discusses all the aspects of the simulation scenario, and having a lot of psychological safety with clear learning objectives. The take-home messages of patient safety could be quite profound. Finally, we come to system thinking. System thinking is how regional anesthesia is a part of our systems of our hospital, how integral it could be if it is so robust that with practice, our blocks are much more effective. Our blocks are giving adequate pain relief. The patient is happy, the feedbacks are good, is when it is time for the regional anesthesia group to make sure that regional anesthesia is a part of the system and how we are going to look into. So regional anesthesia also could be a tool to achieve patient-centric goals or organization goals by advertising or by making aware of the other departments through simulation scenarios. They could be made aware of these modalities available for patient-centric goals to be achieved. For example, on-arrival nerve blocks for immediate pain relief in the ER room for trauma patients could actually create a patient-centric goal to relieve pain as soon as they enter the hospital. nerve blocks for pain relief in ICUs to reduce opioid requirements and help in early weaning from ventilators. Acute and chronic pain services in the hospital could also use regional anesthesia as a base. There are many administrative anesthesiologists on board here, and they would like to know that there's a cost reduction of anesthesia services in resource-limited hospital setups, and RA could be the answer that they may be looking for. Similarly, obstetric units where labor analgesia is profoundly used could also benefit from regional anesthesia. Lastly, but not the least, simulation-based research in regional anesthesia could help us to test our high stakes, to test the efficacy of training, to test the patient safety outcomes. And this will help us to actually achieve our goals much more scientifically. So today's take-home message is simulation in regional anesthesia has a wide application from education, clinical healthcare, and system thinking. It is a near realistic, goal-directed, experiential learning that is scientifically proven to engage adult learners. So my last question to you again, before we all disperse and your dinner is awaited, what did you learn from today's session of simulation in regional anesthesia? And what is it that you take home today? So I would really request all the participants to go back to www.menti.com, enter this code or use this QR code to really type in your learning outcome, your take-home message from today. So that voting begins now. We have a minute of time. So we're eager to hear the answers because our entire team has really worked hard. The faculty, ICA, ClearNet have been actively involved for the last 1 week or so to get this session on board. So your feedback would really help. So could you just give a small answer to this question? Would you all like to see the QR code once again? Need follow-up sessions? Yes, of course, because this is like the retention capacity with the presentation is going to be less. What we are going to learn more is from hands-on. Okay, so actually attending simulation-based workshops is going to help us first to understand simulation as a participant and then as a simulation educator. Definitely, there will be more follow-up sessions, more regional anesthesia workshops that will involve simulation from now on. Thank you for the feedback and your positive inputs. I guess today's session ends here. Thank you very much, ICA. I hand over this session back to you, Dr. Indu. Thank you.
Thank you so much, Dr. Vaibhavi. In fact, thanks to all the 3 speakers for the wonderful talk. And coming to the question answers in the chat box, most of them are their congratulations and like thanks notes. And there is one question: any app for anatomy with respect to regional anesthesia? This is from Dr. Mohan HS.
Yes, there is an app called Essential Anatomy. Okay, I'm just typing in the chat box. That gives us the anatomy quite robustly. Essential Anatomy. One second. Okay, sorry. I think one second. Type it. So Essential Anatomy is an app that gives us a 3-dimensional view of the entire structures, how they interact with each other. This really helps us understand how to approach the nerves when we're giving a block.
Okay. There's one more question. I think this is for Dr. Thilaka. That any skill module for PG anesthesia? I think Dr. Vaibhavi gave a lot of inputs to that. You want to add something?
as such, for postgraduates, it could be like we already mentioned, skill teaching as well as scenario teaching, ma'am. So for PG anesthesia, I think the basic airway teaching where we teach them the basic airway skills. And I mean, is it a general question or not related to this particular talk? I understand. So for postgraduates in anesthesia, the skills learned could be basic airway, BLS, ACLS, point of care ultrasound, ultrasound guided regional anesthesia, and mechanical ventilation on a general basis. And the critical care crisis and the resource management cases are innumerable, like starting from how we manage an ED scenario, to an intubation, to a crashed patient in an endoscopy, to what happens in an OT and in critical care unit. The scenarios are innumerable.
Yeah,
So,
thank you, Thilaka, for the answer. And I think we cannot separate like anesthesiologists from the other team members. We need to empower our teams, the surgeons, the anesthesiologists, the sisters, the OT technicians. They all have to be involved in this scenario so that we get a good team for the good patient outcome. And not only the technical skills, the non-technical skills are very important. Taking consent, like how to manage a case, all these factors can be discussed with them. So as you said, there are innumerable things which can be done. Any more inputs from the other two speakers?
Yes.
No, I'm okay. I think Dr. Thilaka has covered everything.
Yes.
So there is a question here regarding pain control in ICU. In ICU, there are various regional blocks that could be used, and those could be practiced on the simulators, such as thoracic paravertebral blocks, catheters. They could be actually practiced on the task trainers. So that's possible.
Okay. So there are no more questions in the chat box. I think thanks to all the three speakers, and over to you, Dr. Radhakrishnan, sir.
Thank you, Dr. Indu, for coming up with a wonderful team to speak on this particular topic. It's a very carefully executed webinar. I'm so happy you have taken a lot of pains to bring this particular webinar to the most appreciable levels of precision, and we are able to teach us. Well, I'm so happy to say that I was not knowing many great things which you are talking during this particular webinar. That means we all need to be updated. We know a little bit about the communication skills and all these particular matters which you are talking, but we are knowing only elementary things, which means we have to have continued education on this particular matter. And I'm so happy you are able to moderate very well. And I'm really surprised to hear certain new terms regarding the teaching and parting with the knowledge, which Thilaka was telling about the cognitive overload. I doubt whether cognitive overload, whether we can guess even. That means we had to go at a very low pace. That means even the weakest in the group has to understand what is being talked about. That means unless we know what is the cognitive overload of each individual, we may not be able to push all the materials together in one go, which otherwise makes me tell that it should be division, and on each day only a part should go in. Anyway, do you have any other opinion, Thilaka, on this particular matter? Cognitive overload, which you are telling?
So generally, each person's way of learning is different, and how much they learn at what speed is also different. So when we deliver a lecture or when we put everybody in the same platform, what happens is, like you exactly told, some people can grasp things very fastly, whereas some people might grasp things better, provided they do the learning for 2 or 3 times. So to prevent that kind of same platform for everybody, we can give the learners the material beforehand. So they can easily do the learning from their own side in the form of a pre-course content. So the pre-course content need not be only written material, which might not be easy to understand. So it could be audio-visual content, it could be videos, it could be these kinds of webinars. Instead of us delivering it live, suppose I want some cognitive content, for instance, an anatomy to be explained to a student, I can do this and give it to them. So they can repeatedly learn about how many ever times they want to do it. So, and then they can come back to us. So instead of teaching somebody skill and knowledge in the same platform, if we can detach knowledge bit and give it to them beforehand itself and teach only skills in the contact course where we are teaching them skills, that will kind of take care of this cognitive overload, sir.
Thank you, Thilaka, for your opinion.
Thank you, sir. I can see Dr. Dinker's hand also raised on this.
Yeah. Yes, Dinker,
Yeah,
you want to
thank you.
Yeah.
Yeah, I just want to add, I think this is a very important concept, not necessarily only in simulation, but across all education. We have to understand that the capacity, the working memory is limited, and that's essentially what we are talking about when we're talking about cognitive load. So even when we are teaching a specific skill to the residents, we need to break it down into more digestible chunks, and the whole process is called chunking of the skills, so that we don't teach everything from of a complex skill from top to bottom. So we start with smaller components and then later put it all together. So this is just what I wanted to add. Thank you.
Thank you. And again, one particular term which you used, culture of low expectation. Is it common with all of us? Or what do you mean by the culture of low expectation? That means we don't care that much, or we don't hope that much. It could be one of those things. Either we are unaware of expecting many, many things, or rather we are not told. Yeah.
I think I sort of set the cat among the pigeons with that particular statement. I made that statement based upon my own experience of practice of more than 35 years in this country. And traditionally, in fact, when I was involved in simulation pretty early on. And whenever I was talking to others about simulation, the common reaction was, why do we need simulation when we have so many patients from whom we can learn? So that is the sort of resistance, and that is the sort of answers I was getting when I was talking about the need for simulation. What I want to emphasize is that learning on patients obviously comes with several drawbacks, the major one of which is causing harm to the patient. No matter how careful we are in the learning curve, there are some patients we are going to cause harm. But that is something that was an acceptable way of learning for many of us till very recently. And that is what I meant by saying culture of, the low expectations. In surgery, for example, if you see, I know people who will just attend a weekend course in laparoscopic surgery and then start calling themselves laparoscopic surgeons. We don't have a process of accreditation. We don't have a process of qualifying somebody for a particular task. Even our degrees, if you see, at least in surgery, they may achieve their MS without having done many even basic surgeries. And they just then start learning on the job because that process of accreditation is not there. So this is essentially what I was, in a nutshell, what I was saying about a culture of low expectation. And again, as I said, I'm glad to see that it is changing. Simulation, this webinar itself is a thing to note, that people are becoming more and more aware of simulation as a modality of training, and with increased patient awareness and with NABH and other accreditation agencies coming in, this is quality assurance is becoming a major, patient safety is becoming a major buzzword in hospitals. Thank you.
Thank you. Thank you for clarifying that. Unfortunately, the process of accreditation, especially in our clinical practice, is very long. It's only picking up. It may take another 10, 15 years time. As you said very well, well, somebody puts up a board as a consultant. And well, most of us we even don't know what this particular term consultant means and how many years of experience you may have. And your opinion is guarded as a consultant in many occasions. Anyway, these things may take time. Likewise, Vaibhavi also was making a term called a simulation in healthcare and system thinking. Unfortunately, well, we have not heard these terms earlier. That's the reason I am again and again asking. System thinking.
Yes, sir.
And I believe you may be having videos, all the three, Thilaka, Dinker, and Vaibhavi may be having videos on all these particular matters. I mean, very clearly explained videos. If we have these particular videos, we are glad that it could be projected because we have all these things going on to the YouTube at least for a year. This will be going on. And we can put this one also, this particular video. That means if anybody is interested, they may be able to learn it well from. Because the teaching through these sort of webinar sessions may take a lot of time because people have to take their own time, learn it. And if they have any doubt, they may be able to clarify with one of you on their website or on telephone or through some other means. So I was wondering whether you may be having any videos. In that case, if you can share on your name, we will be able to project this on our platform.
Sure,
Because
sir.
I was surprised by that first opening sentence of Thilaka telling that nearly 134 million arrays going on in world every day. Oh, that's too much for me to take. Anyway, thanks. You have done a wonderful seminar because most of our seminars are very carefully picked up topics. And this topic also we want to know. In fact, I was talking with Indu, which are the areas you're going to amplify. And I was so happy that you were able to clarify our doubt and you were able to come very well. I never knew that you are going to deliver so much of things. And I was not at all having the expectation that I'm going to learn so many things by the end of the evening. And we
Thank
are
you so much, sir.
Thank you,
Yeah.
sir. Thank you very much.
yes,
Thank
so
you.
happy that you were able to deliver such a good webinar session.
Thanks a lot.
So, thank you in participating with us.
Thank you.
And well, Indian College of Anesthesiologists, thank you very much for your efforts.
Thank you, sir.
And we request you to stay safe, stay healthy, and please be prepared to come with us at more occasions. And we'll be seeing you next week. Until then, goodbye to you all.
Dr. Radhakrishnan, special
Yeah, please,
thanks
please,
to
madam.
Dr. Dinker
Yeah.
for having joined us.
Please,
The others are all
madam. Please
off.
I was very worried
Family.
as a surgeon coming in among all the anesthesiologists.
Thank you so much.
Wonderful, wonderful.
Thank you.
Thank you.
Okay.
Thank you.
Bye.
Bye.
Thanks a lot.
And last of all, to our Anger Dinker Sarkar, I mean W Sarkar, she has done it wonderfully well today.
Yes.
Thank you.
Yes. And Sanish as well.
Thank you. Thank you,
Thank you.
Thilaka,
Bye.
Dinker, and Vaibhavi. Okay.
Bye-bye.
And all my friends everywhere. Good night to you.
Good night.
Good night.
Bye.
sir. Good
Thank you.
night. Good night, everyone. Bye.
Good night, everyone. Bye.
Good night also. We are closing here for today.
Thank you, Develina.
Thank you so much, ma'am.
Thank you, Dr. Sanish.